This is Justine Sparrgrove, recording the immune system. This is the first part of lecture for Learning Plan 9 for nursing pharmacology. We're going to review drugs for the immune system modulation, Chapter 34. Immunology is the study of molecules, cells, and organs, and the recognition and disposal of foreign matter. This includes how the foreign matter interacts, how their actions can be diminished or enhanced. Immunity. Antibodies are responsible for immunity. They offer protection from a disease. The major function of the immune system is to detect and eliminate foreign substances. Antibodies. Antibodies are proteins that are made to fight specific diseases. Antibodies are made by your body when an antigen, or basically a foreign protein, such as a virus, bacterium, or toxin, enters your body. Once your body develops and makes an antibody, your body never forgets how to make the antibody again. The next time that same antigen works its way inside the body's ready to fight it off, basically in a shorter period of time, usually 2 to 3 days versus, 7 to 10 days. And that's considered immunity. So there are different types of immunity. There's naturally acquired immunity, and then there's artificially acquired medical immunity. Naturally acquired immunity is acquired by your body in a natural way, and artificial acquired medical immunity, or usually we just call artificially acquired, is acquired by an artificial or by medical means. There's also active immunity and passive immunity. Active immunity requires your own body to make its own antibodies, and passive immunity, your body didn't have to do anything to actually require that immunity. These terms put together determine 4 different types of immunity. So first, there's naturally acquired active immunity. Basically, it's made by your own body. Again, 100% body acquired it on its own, and you created your own antibodies to fight it off. So a good example of this is chickenpox. Then there's the naturally acquired passive immunity, which the body acquired it on its own, but your body didn't have to make any antibodies on its own. An example of that is, you may have received antibodies from your mother when you were first born. Some of those antibodies carry over, or sometimes through breast milk if children are breastfed. Then there's artificially acquired passive immunity. So the body did not get it on its own, and it did not make its own antibodies. An example of this is an injection of immunoglobulin. And then there's finally the artificially acquired active immunity. So the body did not get it on its own, but it did make it its own antibodies. So a good example of this is an injection of MMR, or measles, mumps, and rubella, and your own body makes the antibodies to it. So types of vaccines. There's the attenuated or live version. It's basically alive, but it's weakened, so it's unable to produce the disease unless you're immunocompromised. This one, a good example is the MMR, or the measles, mumps, and rubella. Then there's the inactivated, or the killed, which is unable to replicate or cause diseases. Examples here are influenza, HPV, and Hep A shots. Then there's the toxoid, which is a bacterial toxins that have been chemically modified and incapable of causing disease. Here, diphtheria and tetanus. And then finally, there's the recombinant technology, which contains partial organisms or bacterial proteins that are created in the lab. And the example here is the hepatitis B. So assessment. Live vaccines should never be given if the person is receiving steroids, radiation, or anti-neoplastics, has leukemia, AIDS, low white count, or a current infection, received an immune serum within the last 3 months, or is immunocompromised. And all of those are really good examples of being immunocompromised. So again, they should never be given live vaccines. All right, so why? Immune system is weakened, so allows the weakened antigen to produce the disease that we are trying to prevent. Also note that the live virus vaccines are shed for up to 30 days. So one example is, again, the measles, mumps, and rubella. So make sure to educate those receiving it that they need to stay away from anyone who is immunocompromised as well. So a good example is a child gets their measles, mumps, and rubella, and their grandma is going through chemo and stuff. So they're going to want to make sure that they stay away from grandma because they shed that for 30 days and grandma could pick it up. So we also want to make sure that we do a medical history and review their medications. We want to look at signs and symptoms of infections for anybody receiving that. And then allergies, especially to medications like neomycin, chicken, feathers, horses, and eggs, because a lot of these are actually utilized in the development of vaccines. So our planning and implementation. So always make sure that we explain the immunization schedule and reinforce state laws. Make sure that you look at the CDC website and note the ages people should get certain immunizations. We'll also take a quick look at that in class, but please make sure you look at that on your own. Prepare the patient for the injection. Teach about adverse reactions that may occur, such as myalgia, fever, malaise, irritability, rash. Offer possible solutions for reactions. So if they have a fever, Tylenol per their age. If they have a localized reaction, an application of heat or cold, and tell them to use the extremity. The more you let that extremity sit, the more it'll actually stiffen up. So moving it is actually good. Sometimes they need to take cold bathtubs, make them feel better. And then any other comfort measures as needed. Evaluation. So how do we evaluate? So we need to observe them for approximately 15 to 30 minutes following the administration of the vaccine. And most evaluation of vaccines is done by a statistical method. So let's take a look at the different types of immunizations. All right, so starting with passive immunity, again, this would be the antibodies you're injecting into a person. So immune serums, which will be hepatitis B immune globulin or gamma globulin, RSV immune globulin, RHOD or ROGAM, that's commonly what you hear it called, immune globulin, and tetanus immune globulin. The antitoxins and antivenins would include diphtheria antitoxin and tetanus antitoxin. Active immunity includes bacterial vaccines, BCG vaccine, Hemophilus B or Hib conjugate vaccine, and the pneumococcal vaccine. And then viral vaccines. They include hepatitis B vaccine, influenza virus vaccine, Lyme's disease vaccine, MMR, measles, mumps, and polio. And then finally, we have toxoids. And these include diphtheria and tetanus toxoids, and then the tetanus toxoids. All right, so let's review. What are the most common sites for injections? So we're going to give it either a deltoid, vastus lateralis, or ventral gluteal. The ventral gluteal is the most common site. And remember, the deltoid can only give up to 1 milliliter of solution. What are the most common side effects? So make sure you always look to see what the most common side effects are for any medication, because obviously they're not going to be the same. Why is record keeping so important? So as far as record keeping, usually when you give a vaccine, they want to know the manufacturer, the name of it, the expiration date, the date that you give it, where you gave it, so on and so forth. And that's so we can always go back and look at the batch. And if one was infected, you know, if someone was infected, we can go back and contact the people who actually received that batch. What signs and symptoms must be reported to a physician immediately? Any sign of an allergic or anaphylactic reaction would be why we would contact the physician immediately. What conditions would prevent the administration of a live vaccine? Any patient who had an immune system that was weakened or immunocompromised would be a reason why we wouldn't give it. What emergency equipment is needed to be available with injections? So make sure you have a code cart available and any supplies needed for any anaphylactic reactions. How long should a patient be observed after vaccine administration? And we talked about that. It'd be 15 to 30 minutes following the injection. All right, so moving on. Immunostimulants is a biologic response modifier that boosts specific functions of the immune system. So it's basically a booster. It's used to stimulate white blood cells, platelets, and some have antiviral, anti-cancer, and anti-inflammatory properties. So that's basically immunostimulants in a nutshell. They're boosters to help boost anything that they're given for. Now, on the flip side, we are going to talk about immunosuppressant agents, which are drugs that suppress the immunological system. Primarily, they prevent organ rejection in kidneys, heart, and other organ transplants, but most commonly kidneys. It's associated with suppression of T lymphocytes. These cells are believed to actually play an important role in the immunological process, and is used in combination with corticosteroids to improve their efficacy. So the two most common ones here is the cyclosporine and then the azathioprine. All right, so let's review here again for the immunosuppressant agents. What is the most important aspect of assessment and caring for a client receiving immunosuppressant drugs? Watch for those increased signs of immunosuppressant, such as increased temp, keep the patient safe and away from anything or anyone that may compromise them or may get them sick. What lab values need to be monitored? Typically, it's a CBC with white blood cells and platelets. What are live vaccines? Why are live vaccines not administered to immunosuppressed or immunocompromised patients or clients? It's because they have a lowered immune system, and that'll put them at risk for developing the disease that we're actually trying to prevent. And why do we need to monitor intake and output and body weight of someone? That's because they can end up retaining fluids. All right, moving on to chapter 35, drugs for bacterial infections. Pathogens. Pathogens are organisms that cause a disease. Pathogens must bypass the body's defenses, so that may include bacteria, viruses, fungi, intracellular organisms, and or multicellular animals. They cause disease by dividing rapidly to overcome the body's defenses and disrupting normal cell function. And pathogens secrete toxins, so they can disrupt the normal cell function. Pathogenicity and virulence. So pathogenicity is the ability of an organism to actually cause an infection, and virulence is the measure of disease producing potential. So a highly virulent pathogen can cause a disease when present in very small amounts. Basically, it means it's extremely potent. So how do we describe these bacteria? There are different methods for describing the bacteria that most of you have learned or will learn in microbiology. So the basic shapes are the bacilli, or rod shaped, the cocci, which are sphere shaped, and the spirilla, which are spiral shaped. And then we look at the ability to use oxygen. So they're either aerobic or anaerobic. Aerobic is with oxygen, so it needs oxygen to survive. And then there's anaerobic, without oxygen, which means it doesn't need oxygen to survive. And then we look at staining characteristics to see whether the bacteria is gram-positive or gram-negative. Basically, gram-positive means that the thick cell walls it can be retained. So it's something that just shows the thickness of the wall. So gram-negatives aren't quite as thick. We then use this information, so of any of these things, to choose antibiotics that will fight off the gram-positive or gram-negative. Acquired resistance. So pathogen acquires a gene for bacterial resistance, and this occurs through mutation. Antibiotics destroy the sensitive bacteria. Then the insensitive mutated bacteria are all that's left. So most mutations can be random and occur during cell division. And mutated bacteria can actually multiply very, very quickly, more quickly than normal. And they can also be spread by another microbe. So bacteria can get passed on to others. And it's important to note that antibiotics itself do not create mutations. So it's just strictly that a mutation of the bacteria. Here's a good visual of the resistant organism that you can see on that first little dish. So it shows the resistant organism with the infection. And so then you give the antibiotic and everything's killed off except for that mutation, because remember, it's a little bit different. And then over time, or a short period of time, it continues to multiply. So then we get a resistant organism that's left to continue dividing. So widespread use of antibiotics. So the widespread use of antibiotics doesn't cause resistance, but it is worsened by overprescription of antibiotics. So we only need to prescribe them when necessary. And long-term use can increase resistant strains of bacteria. Then there's nosocomial infections, which are basically infections acquired in the healthcare setting. And those are often resistant just because they've kept being exposed. And then prophylactically, we can give antibiotics. And it's sometimes appropriate, not always, but sometimes, for example, in immunocompromised patients or surgical patients, usually need some prophylactic antibiotics. And the nurse should instruct the client to take their full dose of antibiotics. If they don't take the antibiotics until they're done, then the bacteria left in the body actually builds its strength. And next time you try and kill it off with another antibiotic, it builds up resistance and has mutated so much that you need a stronger antibiotic. So it's very, very important to take the entire prescription. And typically we see on day 5, people start feeling better and they decide they don't need to take it anymore. So they stop taking their prescription and decide they'll just save the rest in case they need it. But basically there's still bacteria in your body even though you start feeling better, and you don't feel crummy anymore. And again, the bacteria that's left will build up strength and come back. So please, 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 please educate your patients to take their full prescription. So how do we select an antibiotic? Careful selection of correct antibiotic is essential through the use of culture and sensitivity testing. We can then pinpoint which antibiotic will work the most effectively to kill that specific bacteria. We use that to choose which medication we're going to utilize. There are broad spectrum antibiotics, which basically they kill off a wide variety of bacteria. Pretty much it's a jack of all trades. And then there's the narrow spectrum of antibiotics, which is a narrow group of bacteria very specific to certain bacteria. But it might only do one job, but it does that one job very well. So culture and sensitivity testing is where we grow the bacteria in the lab and identify specifically what it is. And it's usually tested for sensitivity to different antibiotics. So bacteria may take several days to identify, and viruses can take several weeks to identify. So the broad spectrum antibiotics, the jack of all trades, get started before the lab culture needs to be started before the lab culture is completed. No, I said that backwards, sorry. We need to do the lab culture, and then we need to start the broad spectrum antibiotic. So that way we can start to fight off the bacteria right away until we get that culture and sensitivity back telling us specifically what it is, and then we may use a narrow spectrum antibiotic. And the culture and sensitivity or specimen must be obtained prior to beginning the antibiotic therapy. So like I said earlier, they tried flipping on you guys. Always get the specimen first or the lab draw first and then start the antibiotics. And that's because if we do it after, then we may get false results, and it's because the antibiotic has already started to work, so we won't have accurate data. Superinfections, these occur when too many host flora are killed by an antibiotic. Host flora are located within your gut to prevent growth of a pathogenic organisms. We usually call this our good bacteria, basically. And broad spectrum antibiotics do not care what bacteria is in the area and kills the good and the bad. When this happens, pathogenic microorganisms have a chance to multiply, and this is called opportunistic bacteria. So basically, they take advantage of the suppressed immune system. So signs and symptoms to include are diarrhea, bladder pain, painful urination, or abnormal vaginal discharge for superinfections. There are some different host factors that can influence the choice of antibiotics. Those include the immune status, so make sure that we assess how their immune status is, the local condition or the site of the infection, if they have had an allergic reaction in the past, their age, pregnancy status, and genetics. So the role of the nurse with antibiotic therapy. We need to monitor the client's condition, provide client education, obtain medical, surgical, and drug history, assess the lifestyle and dietary habits, obtain description of symptomology and current therapies. We need to also obtain specimens prior to start of the therapy. So that would include the culture and sensitivity. So always get the lab before you give the antibiotic. Monitor for indications of response to the therapy. So what should we be seeing? We should be seeing a reduced fever, normal white blood cell count, improved appetite, and absence of any symptoms that they had. And observe for allergic reaction after an IM injection for at least 15 minutes afterwards. We need to monitor for superinfections. So we need to replace that natural colon flora using a probiotic supplement or cultured dairy product. And teach the clients to wear a medic alert bracelet if they're allergic to any antibiotics. Report symptoms of allergic reaction, and to never stop taking the drug until it's completely taken. Antibiotics. So bactericidal, kill or suicidal. So bactericidal, suicidal, kill bacteria. Used for severe infections where patient has a poor immunity. And then there's bacteriostatic, which inhibit the growth of susceptible bacteria rather than killing them immediately. They will eventually lead to bacterial death. And the thing here is that the bacteriostatic is more specific, and bactericidal kills everything. It wipes everything clean. And the bactericidal is where we usually see the normal flora killed off. General principles of antibiotic therapy. So assessment the patient before, during, and after the treatment. Antibiotics treat infections. Sometimes antibiotics are given before the organism is identified. These again would be the broad spectrum, are the ones that we would be giving. Antibiotics are given prophylactically sometimes, and therapeutic response is present when an antibiotic therapy is effective. Superinfections may occur. So antibiotics reduce or completely eliminate the normal bacterial flora. Antibiotic interactions can occur between food and other drugs. A lot of those are on the concept map on Schoology there. So you can use that as a study guide to help you remember some things. And host factors can cause antibiotic therapy to be successful or not successful. Some more general principles of antibiotic therapy include antibiotics can cause teratogenic effects in an unborn fetus. So make sure you pay attention to the pregnancy category. Certain antibiotics depend on specific enzyme systems to break them down so they can be eliminated from the body. Some patients have genetic deficiencies that result in antibiotics having an abnormal effect. The anatomic site of an infection is important. So a good example would be the cerebrospinal fluid, or CSF. They must have a drug that crosses the blood-brain barrier to actually work. So you can't just give them whatever you want. And the route of administration, dose, and duration of therapy are also very important to take into consideration. All right, so let's look at our antibacterials. There are 8 of them. They are penicillin, cephalosporin, tetracyclines, macrolide, aminoglycoside, fluoroquinolone, sulfonamide, and then our miscellaneous categories. So we're going to go through each one individually here. So penicillins are most effective against gram-positive bacteria, and they work by inhibiting bacterial cell wall synthesis. It's a narrow spectrum drug overall. It was introduced in 1941 and remains a safe and effective antibiotic. And they're part of a large group of chemically related antibiotics derived from fungus or mold. Usually this is what we see growing on bread or fruit. So its therapeutic uses, it's gram-positive. It's usually against the Enterococcus, Streptococcus, and Staphylococcus bacteria. The common side effects and adverse effects include nausea, vomiting, diarrhea, decreased red blood cell count, white blood cell count, and platelets, and abdominal pain. Allergic reactions usually include urticaria, pruritus, rash, angioedema, resulting in anaphylaxis, and only 10% of those are actually fatal. And then there's the idiopathic reactions that may occur, such as Stevens-Johnson syndrome. So Stevens-Johnson syndrome is a serious adverse effect. It affects the integumentary system. It includes photosensitivity, exfoliative dermatitis, and again, it's the Stevens-Johnson syndrome. Bacteria produce enzymes capable of destroying penicillins. This is called beta-lactamase, and this would deem the med no longer effective. Chemicals have been developed to inhibit these enzymes called beta-lactamase inhibitors, and those include clavulanate, tazobactam, sulbactam, and avibactam. And these chemicals actually bind with the beta-lactamase and prevent the enzyme from breaking down the actual penicillin. So we need to make sure that we carefully monitor for allergic reactions at least 15 to 30 minutes after it's been administered. And the effectiveness of oral penicillins is decreased when taken with caffeine, citrus juice, cola beverages, fruit juices, or tomato juice. Make sure that our patients avoid cephalosporins if the client has a history of severe penicillin allergy, because they are in the same class, I guess. Monitor for hyperkalemia and hypernatremia, and monitor for cardiac status or ECG changes. All right, cephalosporins are semi-synthetic derivatives from a fungus. They're structurally and pharmacologically related to penicillin. Basically, it's like a sister. The action is a bactericidal, again, bactericidal, suicidal, so it kills. It's broad spectrum, so it kills many gram-positive and gram-negative bacteria. It's divided actually into 4 generations according to their antimicrobial activity. So we'll go through those as well. But make sure that we always have our patients take all their cephalosporins with food or milk. So the first generation, we usually see Keflex, which is oral, and often it's used if the patient has an allergy to penicillin, and it's used for otitis media. Then we have the cefazolin, which is IV, and it's primarily used as a prophylaxis postoperatively and used for upper respiratory infections. It's a good gram-positive coverage, and it has poor gram-negative coverage, though. Our second generation has good gram-positive coverage. It has better gram-negative coverage than the first generation. Not perfect, but it has better coverage. The medications that we see most commonly here are Ceclor, which is oral form, Cefitan, which is IV or IM, and then Mifoxin, which is IV. And that one's prophylactically for abdominal and colorectal surgeries. Our third generation is actually the most potent group against gram-negative, but it is less active against the gram-positive. So we're flipping the other way here. Common ones here is the ceftazidime, which is IV. It's a drug of choice to treat Pseudomonas infections. And then we have the ceftriaxone, which is IV or IM. This one has a long half-life, and it's only actually used once a day dosing. It's used most often today. And it easily passes through the meninges and diffuses into the CSF to treat CNS infections. And then we go through, actually there's 5 generations, 4th and 5th generation. 5th isn't much for a generation, but it is there. 4th generation is the cefepime, which is IM or IV. It's twice per day dosing and capable of interacting with CSF to treat CNS infections. And then there's ceftaroline, which is effective against MRSA. So let's look at some cephalosporin side effects, which include nausea and vomiting, diarrhea, abdominal pain, skin rash, and fever. We need to use these with caution, especially in patients with a history of GI disease, such as colitis. It does have a cross-reaction that could occur if the patient has an allergy to penicillin. Then they could actually be allergic to the cephalosporins, because again, they're sisters. But the percentage of that is only like 1 to 7, so it's very small. And these also, the cephalosporins may also cause nephrotoxicity, especially in earlier generations, and especially if poor renal function or taking aminoglycosides or on diuretics. Nursing implications: assess for presence or history of bleeding disorders, because cephalosporins may reduce prothrombin time, or prothrombin level, assess the renal and hepatic function, and avoid alcohol. Some cephalosporins actually cause dyspholoram or anabuse-like reaction with alcohol. All right, tetracyclines. These are natural and semi-synthetic. They act as a bacteriostatic. They inhibit protein synthesis. Our common ones here are tetracycline and doxycycline and tigecycline, which is IV form, and it's newer and actually used for MRSA. And notice that they all have cycline after tetracycline. Make sure this one does not get given with milk or dairy products, because they actually reduce the absorption of the drugs. Tetracyclines are wide spectrum use, the gram-positive and gram-negative. Also effective against protozoa, mycoplasma, rickettsia, and it's basically used most oftenly for chlamydia, syphilis, Lyme's disease, and peptic ulcer diseases caused by H. pylori. Some more on the side effects: strong affinity for calcium, and it will decrease the absorption by 50%. So that's talking about, no dairy or milk with it. There could be a discoloration of permanent teeth and tooth enamel in fetuses during the second and third trimester and with children, so it cannot be given to pregnant women. It may also retard fetal skeletal development if taken during pregnancy, and it's actually a pregnancy category D for those reasons. Common side effect, or not common, I guess, a side effect can be maculopapular rash, and alteration in intestinal flora may result in a superinfection or the overgrowth of the non-susceptible organisms such as E. coli, resulting in diarrhea or pseudomembranous colitis. So what is your role? So knowing that it's contraindicated for clients who are pregnant or lactating, because it can affect the linear skeletal growth of a fetus or child. Know that it's contraindicated in children less than 8 years of age and may cause permanent mottling and discoloration of teeth. Tetracyclines decrease effectiveness of oral contraceptives, so make sure you tell your patients to use alternative birth control methods. Make sure they use it with caution in clients with impaired kidney or liver function. Photosensitivity may result, so they're going to want to make sure that they stay out of the sun or use sunscreen. And don't take it with milk products, iron supplements, magnesium-containing laxatives, or antacids. All right, our fourth one is macrolides. This is chosen if a patient is actually allergic to penicillin. It is gram-positive and gram-negative. It's a bacteriostatic and bactericidal in certain species. Common ones here are erythromycin, which is older, very irritating to the GI system. And then there's azithromycin, which is a 5-dose pack. Adults usually get 500 milligrams per day, then 250 for 4 days after that. So do not take it with food. Take 1 hour before or 2 hours after a meal. And this one's actually real popular due to the convenience of only having to take 1 pill a day for only 5 days. So most people do better on this one. And then finally, there's the clarithromycin, which is for peptic ulcers, and the fidaxomicin, which is PO form for C. diff. It's most commonly used for streptococcus, so strep A or sore throat, mild to moderate upper respiratory infections, so a lot of times Haemophilus influenza, spirochetal infections such as syphilis and Lyme's disease, and then gonorrhea, chlamydia, and mycoplasma. Side effects include having a regular allergic reaction, nausea, vomiting. GI usually affects primarily with erythromycin, diarrhea, abdominal pain, hepatotoxicity, jaundice, and anorexia. Newer agents have fewer side effects, longer duration of action, better efficacy, better tissue penetration, and those usually are the azithromycin and the clarithromycin. So what is your role? Assess for presence of respiratory infection, examine client for history of cardiac disorders, monitor hepatic enzymes with certain macrolides such as erythromycin estolate, and know that there are multiple drug-on-drug interactions that can occur with macrolides. Fifth one, aminoglycosides. They are natural and semi-synthetic. They're very potent antibiotic with serious toxicities. It has a very narrow therapeutic range. It is a bactericidal and kills mostly gram-negative and some gram-positive bacteria. It can cause serious toxicities, and we must monitor drug levels to prevent toxicities. So that's usually the peak and trough levels. Common ones here is the gentamicin, which is, again, the most common in this class. And there's tobramycin, amikacin, and neomycin. So let's review our peak and trough levels. Spend a little while. So our peak is the highest plasma level achieved by the administration of a single dose of the drug. It's usually drawn 30 minutes after the dose is completed. And the trough, which is the lowest concentration of the drug in the body, is drawn 30 minutes before the next dose or within the 30 minutes of the next dose. And the key is to make sure that we keep it in the therapeutic range so it's not toxic. Side effects include ototoxicity, nephrotoxicity. Make sure that we do the peak and trough levels to evaluate therapeutic index, which is, again, very narrow. Paresthesia, neuromuscular blockade. Respiratory paralysis can happen if we use with or shortly after anesthesia or muscle relaxants. Skin rash, fever, and superinfections. So what is your role? Monitor for ototoxicity and nephrotoxicity. Hearing loss can occur after the therapy is completed, so we want to pay attention to that. Neuromuscular function may also be impaired. Increase fluid intake to promote excretion unless otherwise contraindicated. The sixth one, fluoroquinolones. This one is the first oral antibiotics effective against gram-negative bacteria, along with gram-positive for newer generations, though. It's excellent oral absorption. You'll actually see that the oral form is as effective as IV antibiotics. Absorption reduced by reduced by antacids, so leave an hour or two mark before and after taking the medication. It's a bactericidal, and it alters DNA of bacteria causing death, but this doesn't affect human DNA. So most common oral or IV is ciprofloxacin, which is a second generation, levofloxacin, which is a third generation, a preferred IV form, and moxifloxacin is the fourth generation, and it's the newest, and it's usually IV form. Therapeutic uses include lower respiratory tract infections, bone and joint infections, infectious diarrhea, urinary tract infections, skin infections, and sexually transmitted diseases. Side effects to look for include musculoskeletal, so tendinitis, so ruptured Achilles. One way to help you remember this is that your Achilles tendon is in your leg, and your leg touches the floor for fluoroquinolone. Okay, so fluoroquinolone should automatically trigger you to think Achilles tendon or tendinitis. CNS includes dizziness, fatigue, depression, and restlessness. GI includes nausea, vomiting, thrush, increased liver function enzymes. And drug interactions could include increased prothrombin time when taken with warfarin. So what is your role? We need to monitor white blood cell count, monitor clients with liver and renal dysfunctions, teach that drugs may cause dizziness and lightheadedness, so advise against driving or performing hazardous tasks during the drug therapy. Teach that the drug may affect the tendons, so again, fluoroquinolone, tendons, leg touches the floor, especially if the patient's over 60 years old. And those using corticosteroids, and this one is actually not approved for children under the age of 18. Number 7, sulfonamides. This one is a broad spectrum and bacteriostatic. It's used to treat UTIs, pneumocystis, carny pneumonia, ear infections, bronchitis, gonorrhea. Used as an alternative drug if patient is actually allergic to penicillin. It antagonizes or inhibits an enzyme, folic acid, to be specific, that is essential for bacterial growth. Most commonly, Bactrim is used, and this treats gram-negative bacteria, E. coli, and UTIs. Topically, it's sulfadiazine, which is used to treat corneal ulcers and conjunctivitis. Side effects. In the GI system, nausea, vomiting, diarrhea. Kidneys, so toxic to nephrosis and crystal urea may happen. On the blood, hemolytic and aplastic anemia and thrombocytopenia. Integumentary, photosensitivity, exfoliative dermatitis, and Stevens-Johnson syndrome. And some others can include convulsions and urticaria. And our preventative measures is to make sure that they drink 3 to 4 liters per day unless contraindicated due to the flushing the antibiotic out of the body. So what is your role? Assess for anemia and other hematological disorders. Assess for renal function. They actually may increase risk for crystalluria. Contraindicated in clients with a history of hypersensitivity to sulfonamides because it can actually induce skin abnormalities such as the Stevens-Johnson syndrome. And teach a client how to decrease effects of photosensitivity, such as wearing sunscreen or staying out of the sun. Our last section is our miscellaneous ones. So they're the ones that are of importance, but isn't enough of them to be in their own specific categories. This includes clindamycin or cliacin. It's for oral infections caused by bacteroids, associated with Fusobacterium and Clostridium perfringens. And then there's the flagell, which is used to treat H. pylori infections of the stomach. Make sure this one does not get taken with alcohol because it can cause the antabuse type of reaction. Then there's the vancomycin, which is effective for MRSA infections. Adverse effects of this one is ototoxicity, nephrotoxicity, red man syndrome. It's really harsh on veins. And this one, you have to have a peak and a trough level drawn. Then there's the linezolide, which is as effective as vancomycin against the MRSA. And then there's the primamycin. This one's of importance because it has the broadest spectrum of any class of antibiotics. All right, and finally, tuberculosis. Tuberculosis is caused by Mycobacterium tuberculosis. It's due to cell wall resistant to an anti-infective. Basically, the body's immune system responds by trying to isolate the pathogen by walling it off. Tuberculosis may remain dormant in that walled off area, which is actually called a tubercle, and that may happen for a long time before it becomes active. So as soon as their body has a decreased immune system, then that basically gives the tuberculosis an opportunity to become active. Tuberculosis, so it's a long-term therapy. You need to take it for a long time if you're diagnosed. Usually 6 to 12 months of drug therapy needed to reach isolated pathogens in the tubercles. Therapy must be continued even if no symptoms are present anymore. A client with multi-drug resistant infections requires therapy for 24 months typically. 2 to 4 antibiotics are administered concurrently, and different combinations are actually used during course therapy. This is necessary because Mycobacterium grows slowly and is commonly resistant to therapy that was initiated with the first choice drugs. So when the resistance develops, a second choice drug is used, and they're more toxic but less effective than actually the first choice drugs. So the pharmacotherapy includes INH, and this may be used in combination with rifampin as a preventative therapy. And tuberculostatus and tuberculocidal effect can occur with pharmacotherapy. INH is pretty low cost, and it's relative effectiveness of safety. So it's fairly safe. The side effects can include skin rash, headache, vertigo, nausea, jaundice, and peripheral neuritis. A lot of times we give this with B6 pyroxidine to counteract the effects of this problem, since there is a deficiency of B6 caused by the INH. And that is it for the first part of the lecture for Learning Plan 9. Remember that there is a second half, so make sure that you listen to that as well.